In my talk, I really would like to focus on the E-negative disease, as you can see here from the current guideline we have, that there's around the globe really consistency and agreement. There's EE seroconversion when achieved under NUC after having a consolidation period can be regarded as an endpoint for treatment where you can safely stop. But all guidelines do recommend only to stop in patients without cirrhosis. So even in the E-positive with seroconversion, there's a concern of reactivation and decompensation. So the controversy exists here in the E-negative disease, where in the APASL, you know that all patients having 3 times undetectable levels of HBV DNA under treatment, 6 months apart, fulfill criteria for stopping treatment. So in other words, nearly everyone having now these very effective drugs will stop treatment after 3 years, more or less. The ACLD is very conservative. You say, well, you have to treat indefinitely. Even if you have an S loss, discontinuation may be only considered, so no strong recommendation. And EASL, more progressive this time. It was also the indefinite recommendation, but now they decided it may be considered, and the wording is depicted here, that discontinuation of NUC in selected non-cirrhotic E-negative patients who achieved long-term suppression, at least 3 years, may be considered if close monitoring can be guaranteed. So a lot of very be careful in one hand, but we feel there's something behind, and the evidence or the recommendation is coming from a lot of data, most of them retrospective data, some prospective but non-controlled data, only one controlled data, but showing in comparison what Harry has shown you, that you normally have no S decline and no S loss in E-negative disease on treatment. We have a significant number of patients achieving S loss when stopping NUC and followed for the long term, ranging from 13% to up to 50% in between several years and up to 6 years. And the only randomized, this is our study, it's a pilot study here with in total 42 patients. We have no S loss in the control arm, but 19% S loss in the stopping arm at year 3. So the question I was asked to answer is, when is it beneficial and when it's dangerous? And I think it really depends on the definition. So do we feel that it's only beneficial if there's really no relapse, or if we achieve a state where patients do not fulfill treatment criteria, or is it really S loss as a beneficial endpoint? And on the other hand, what is really dangerous? Is it any ALT flare increase or HBV DNA rebound? Because you have to be aware that the patient is completely suppressed, he's in a healthy state, and so is it dangerous, or is it only a severe hepatitis flare, or the decompensation with death? Of course, this is dangerous. And is there any concern with an increased HCC risk? So the question here is what we are really aiming for, and for what we have data from the literature. And here, I think the problem we are facing is that most studies so far focused on only the virologic or biochemical relapse as a main outcome measure. And it was always believed in all these studies coming from Asia that beneficial is having no relapse. And the other point I mentioned is that most studies are coming from Asia, where the stopping is not part of a clinical trial, a prospective follow-up, but it's part of the routine and probably mainly driven by cost constraints. So I think we really have to realize that when stopping NUC, this results quite frequently in virologic and biochemical relapses, and this runs through different phases. And this can be explained here. If you stop first, you have a kind of a lag phase where nothing happened, and this lag phase is followed by some reactivation. Typically, DNA will increase, but this enters into a consolidation phase where this flare can be transient. HBV DNA can either become negative or still there's some level of replication. And in the end, you will, in the long term, end up with some outcome categories, and this could be on the one hand as loss in about 20%, or really a healthy carrier state, sustained virologic response. Some patients already have a decline in S antigen level, about 20 to 30%, and those entering again a chronic hepatitis and need retreatment. And there's a fourth group, kind of an intermediate state, if you like, not fulfilling either the healthy carrier, not the median treatment criteria, and we have to follow these patients whether they will end up in this or in this category. So we really have to better understand what happened during these phases and how to monitor these patients in order to better judge what to do and when it's beneficial or when it's dangerous. So indeed, I think we have to be aware, and these are data from all the Caucasian studies, that a rebound in HBV DNA is really universal. You cannot say beneficial as you have no or you have it. The discrepancy comes from the Asian studies where it's more variable. You see at month 3, 40 to 49% with virologic relapses, but increase. But please be aware these are all retrospective data. It's not a very close follow-up. You may miss some flares. And if you look at Asian studies with a closer, more prospective follow-up, you see also nearly all patients at any time within 1 year will have a virologic relapse. But what is interesting and confirmed in the second study, that it makes a difference as a lag phase, time to relapse, whether this patient was pre-treated with entecavir or tenofovir, and the time to relapse is much shorter with tenofovir. You see it here in this left-hand side, 2 months as compared to 6.2 for tenofovir, much shorter time to relapse as compared to entecavir. This also holds true for the biochemical relapse. And this was recently confirmed in another large study where you can see that relapses, and these are virological relapses, start as early as 2 to 4 weeks after stopping tenofovir, but only starts 12 weeks later in the entecavir pre-treated patients. Now let's move forward to the reactivation phase, and I think the typical picture of this reactivation phase is depicted in this slide from this stopping trial. It's normally that you have an increase in HBV DNA, and this is followed by an ALT increase. This can be transient, as I've mentioned, and in a good scenario, this can be followed by a decline in HBs antigen. But the concern we have here, and this is a dangerous scenario, I called it number 1, that these reactivation may be associated with severe flares and hepatic decompensation. And in the next slide, I can show you 2 of our patients from the finite study. There were 2 of 21 out of 21, so approximately 10% of the patients in our study developed a significant and severe flare. So, and this flare was preceded, as you can see here, by a really huge and marked rebound in HBV DNA to 7 and 8 log, and then followed by the ALT increase to 500 and 1,000 units. Here the black dots treatment was reintroduced and patients recovered. There was no bilirubin increase, no INR increase, but a significant flare preceded by high viral load quite rapidly. So what is the evidence from the literature with the risk of severe flares? I would like to show you here one European-Asian collaboration study, and I depicted here severe flare as ALT 10 times the upper limit of normal, and as you can see, quite similar as in our finite study, approximately 10% of patients being all E negative developed this significant flare, and all of them more or less within the first 3 to 6 months. In the Daring B, it's a prospective stopping trial from Greece, from George Papadidouridis, now published in Antiviral Therapy. Again, ALT greater than 10 times upper limit of normal in 7%, 4 out of 57. No patient developed bilirubin increase, no sign of liver decompensation. And if you look at more significant flares, this means HBV DNA greater than 20,000, ALT increase. Again, 25% all within the first 6 months or 3 months. This slide summarizes all the evidence I could find from reported fatal outcomes due to hepatic flares and decompensations after stopping NUC. There was some data quite early on with case reports. 2 patients died after stopping, and both had cirrhosis. I think best evidence come here from the Yang study. It's a really large study with nearly 700 patients, and 45 of them had liver cirrhosis, which is very interesting, all negative at the beginning. And you see the hepatic decompensation overall was 1%, but in the cirrhotic group it was 3%, and 3 out of these 9 patients died, although treatment was introduced. I can't tell you whether it was early enough, but nevertheless, and of course all of these patients had liver cirrhosis. The study by Cure, decompensation not mentioned, but there was 1 patient dying with a liver cirrhosis, 0.2%, and the study by Chen, no cirrhosis included at baseline. There were 2 decompensations, but no deaths and no cirrhosis in this group. And there are more recent reports, but these are studies in E-positive patients where treatment was stopped after seroconversion, and there was also 1 death reported with a patient probably had a cirrhosis at baseline. People were not aware, but here 1 patient probably without cirrhosis, 0.7% after seroconversion and then seroreversion. So, to summarize, the flares observed during the reactivation phase are often transient and most likely represent a trigger for inducing long-term HBV-specific immune control. The difficulties here we are facing is how to distinguish beneficial flares from severe and potentially risky flares, and how to monitor and when to start retreatment. There's an interesting whether the differential patterns of ALT, HBV DNA, and HBs antigen may be of help. In other words, if ALT peaks, and at this time we already see a decline in HBs antigen or a decline in HBV DNA, this could be a beneficial flare, ? Or whether we have an ALT peak and HBV DNA is still increasing, HBs antigen level stable, whether this is a risky flare. Some evidence from the literature, these are 2 case reports published recently in Gastro by Jung-Fan Liaf. And you see here a patient suffering a flare with 300 ALTs. The HBV DNA was around 5 log. But during this flare, as you can see here, let me show it. The HBs antigen level are already declining and no increase, and at the end, without treatment, this patient, although having a significant flare, loses S. On the other hand, with the ALT flare here, we have an increase and further increase to HBV DNA level significantly higher, 8 log, in comparison to 5, and HBs antigen levels increasing, and then NUC treatment was started. Are there any predictors of clinical relapse? Well, I think the best we have so far from all these cases I have shown you, our own experience, it's a rapid increase and marked increase in HBV DNA quite early on. Here in this study, greater than 200,000. This was related with clinical relapse as compared to less pronounced HBV DNA elevation. And 2 recent studies also associating the quantitative anti-HBC levels with clinical relapse. I think this is something we have to study further, where they could show that if you have a very low anti-HBC levels, less than 100 in both different studies, this was associated with a more rapid clinical relapse. However, as I mentioned in the beginning, what does it really tell you if you have a clinical relapse, if you have a flare, if we are aiming for S loss? And therefore, I would like to show you 2 studies where S loss was put into association of the flares. And these are 5 patients with S loss from a recent study. And you see there are patients with S loss having an ALT and an HBV DNA flare, and others without. So very difficult to judge what to do with these flare patients. And the same holds true from the landmark Hatziane study, where you can see that in all 13 patients losing S in the long run, many of them had ALT flares, even significant, and also HBV DNA. So it's not a clear picture, but probably the HBV DNA rebound was not as high as in those requiring treatment. But what is intriguing to see that in those patients without S loss, but without retreatment, because they're really in a healthy carrier state, we haven't observed ALT flares. So it might be some association with at least some ALT elevation and a good outcome. So it's really the importance with retreatment matters and when to start retreatment. And from the FANG study we have shown you recently, it was nicely demonstrated that if you start immediately treatment, if a patient had a biochemical relapse, you may prevent S losses. There was 0 S loss in the long term. If you wait, no immediate retreatment, although there's a biochemical relapse, in this group, the patient achieved nearly 20% S loss. But the interesting part in this study that the highest loss rate were really in those having very low HBs antigen levels at the beginning and had no relapse at all. But this is probably a special ACE situation. Well, I would like to come to the end, a brief words to the consolidation phase. So what we consider is a consolidation phase. Well, this starts when HBV DNA, ALT, and HBs antigen levels have reached a kind of a plateau and shifts into the long-term outcome. But the duration of this phase is undefined, but concerning HBV DNA and ALT, our experience is that this is normally reached within the first 48 weeks after stopping a kind of a plateau. In contrast, HBs losses can still occur several years after NUC discontinuation. So the consolidation phase should therefore be considered as important for immune control development. But the dangerous scenario too, I would like to address is whether there may be an increased risk of HCC due to this transient elevation of HBV DNA, these flares in patients being controlled so far. I can't give you really a huge evidence on the HCC incidence after stopping treatment. Again, the best study is a Yang study where they looked at HCC incidence after stopping in this huge patient population, and you see overall the annual rate was 0.7% with a 3- and 6-year cumulative incidence of 2% and 4% respectively. Significantly higher in those starting with cirrhosis reaching 9%. So is it increased? And the beauty of this study is that they compared this HCC incidence after stopping with the HCC incidence they observed on treatment, and this is depicted here, and you see overall the HCC incidence on treatment overlaps or really mirrors the HCC incidence observed after stopping, 0.7 and 2%, no 6-year data because patients stopped early, and a higher risk in cirrhosis, again quite similar to those after stopping. So far, no signal, but I think of course we need more data. Well, to summarize, discontinuation of NUC frequently result in a virologic and biochemical relapse that runs through different phases. I mentioned the lag, reactivation, and consolidation phases. These flare observed during the reactivation phase often transient and most likely represent a trigger for inducing a long-term HBV-specific immune control and therefore do not need immediate intervention but close follow-up evaluations. Severe flares seem to be always preceded by a high HBV DNA rebound, 6, 7, 8 log, quite early on, and flares with liver decompensation and deaths may be probably only observed in E-negative patients with cirrhosis. So in order to guarantee a safe and effective outcome of NUC treatment discontinuation, the NUC retreatment should be initiated timely enough to prevent harm for the patient, but virologic and biochemical flare should be tolerated to some extent to allow the establishment of a functional cure with loss of HBs antigen, and new biomarkers are definitively needed to help to guide us what to do. And I think there are two important prerequisites for the physician and the patient. Of course, we are talking only in E-negative disease without advanced liver disease. And if you consider stopping, the physician should be an expert in treating B, only start in those with mild disease and manage the patient like one being enclosed in a clinical trial aiming for functional cure. And the patient must be motivated to stop and adherent to close follow-up and have to understand the concept of finite treatment that includes also developing a flare. So I think if you fulfill all these criteria, long-term suppression, probably better 4 years, no advanced disease, post-treatment monitoring guaranteed. It would be ideal to have better predictive marker in order to exclude the 40-50% that will end up with retreatment, and then I think you can safely stop. Thank you very much for your attention.